Welcome to the Osteoarthritis Action Alliance Lunch and Learn for March 2015. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today. I am pleased to introduce our presenter, Kelli Allen. Dr. Allen is a research professor at the Thurston Arthritis Research Center at the University of North Carolina at Chapel Hill. She is also research health scientist and associate director at the Center for Health Services Research in Primary Care at the Durham VA Medical Center. Dr. Allen also sits on the steering committee of the Chronic Osteoarthritis Management Initiative, which seeks to revolutionize management strategies for OA in healthcare systems and among healthcare providers. And she lends her expertise to the OA Action Alliance, the Physical Activity Working Group. As a health services researcher and exercise physiologist, her research focuses on improving care and outcomes for patients with osteoarthritis and other musculoskeletal conditions in primary care settings. Her research also explores ways to reduce healthcare disparities and promote informed decision-making among women and racial and ethnic minorities. Speaking for our UNC team and for the OA Action Alliance, we are certainly grateful for all that she does, and we are honored that she has agreed to speak today on patient and provider interventions for managing osteoarthritis in primary care. Welcome, Dr. Allen.
Thank you, Kirsten. Thanks to the OA Action Alliance for giving me an opportunity to talk to you about this work today, and I look forward to maybe some interaction with some questions at the end. So just a little bit of background about kind of what motivated this research. Really, it's from a lot of prior studies that have shown that there are gaps in the management of OA. And I'm going to talk about those in two different areas. First is at the patient level. We know that a lot of patients really have limited knowledge about their OA and its treatment strategies. With regard to physical activity, the vast majority of individuals with OA don't meet DHHS recommendations, and a lot of them are really quite inactive. With respect to weight, the majority of individuals with OA are overweight, and about a third are meet criteria for being obese. And overall, there's low use of community-based programs for OA management. There have also been some studies that have shown there are gaps that exist in OA management at the provider or health system level. Across studies that have looked at various sets of quality indicators for OA management, the pass rates have ranged somewhere between 22 and 55%, depending on the population and the set of indicators. And in particular, what these studies have highlighted is that there are low rates of use or referral to conservative, non-pharmacological strategies for OA. So things like physical therapy, exercise programs, weight management programs, knee braces, and the like. One particular statistic from a recent study is that among people who eventually went on to have joint replacement surgery, only about 10% have seen a PT for knee OA in the 5 previous years. So all of these data really led us to the work that I'm going to describe today. We have 2 parallel studies that are both called Patient and Provider Interventions for Managing Osteoarthritis in Primary Care. I'll refer to them as PRIMO. And the objective of these studies is pretty much the same for both, and that is to examine the effectiveness of patient, provider, and combined interventions for improving OA outcomes in the primary care setting. One of these studies that I'm just going to mention briefly today is an NIH-funded clinical trial in the Duke Healthcare Network. That one you're seeing on the screen now, the study design. We just finished outcome assessment for the primary time point about a week ago, so analyses are ongoing. We'll have results to share soon. Today, I just wanted to tell you what we're doing. That's a 4-arm clinical trial, and you can see the diagram of our study design there. We randomized 10 primary care clinics to either receive the provider OA intervention or be a provider control clinic. And then in each of those sets of clinics, patients were additionally randomized to either the patient OA intervention or patient control. So again, ending up with 4 different possible assignments for patients in that study. We enrolled a little over 500 people with hip and knee osteoarthritis. They all had to be overweight, BMI 25 or greater, and to be physically inactive, so not meeting DHHS criteria. Those are the same inclusion criteria as for the other study I'm going to talk more about in a few moments. The interventions for these studies, the patient-provider interventions, are also the same as the ones that I'm going to be talking about in these slides. So the study I'm going to focus on today is a study that was funded by VA Health Services Research and conducted at the Durham VA Medical Center. This was a little bit of a simpler trial. It was a 2-arm randomized controlled trial. Participants were assigned to either a combined patient and provider, OA intervention, or usual care. Providers were actually the unit of randomization. We enrolled 30 ambulatory care service providers at one VA medical center, and then we enrolled 300 of their patients with the same inclusion criteria I mentioned: hip or knee OA, BMI 25 or greater, physically inactive. And for this study, we aimed to enroll 5 white and 5 non-white patients from each enrolled provider. I can tell you more about the details of that later if there's time, and how successful we were there. We had some provider attrition over the study, so we had to juggle that a little bit. But we did end up enrolling equal numbers of white and non-white participants because we were really interested in looking at racial differences and wanted to be able to do that. Our outcomes that I'll talk about in a little bit were assessed at baseline 6 months, which is kind of an interim time period, and then the primary time point was at 12 months. So a little bit first about our patient intervention. It was 12 months, and it was delivered by telephone. We talked to participants biweekly for the first 6 months and then monthly for the next 6 months. And these were conducted by a health counselor, a health educator who had training in all of the components I'll mention in a minute, as well as in osteoarthritis. So we focused the intervention on 3 main things that have prior evidence base for being effective in hip and knee OA. And so this study was really not about looking at the efficacy of those things. We know that physical activity works. We know that weight management works. It was really on trying to see if, what I would say is effectiveness. Can we take these things and roll them out in an intervention that can be disseminated widely? So again, these were physical activity, weight management, cognitive behavioral pain management skills, or coping skills. And throughout the intervention, we had a strong emphasis on goal setting and action planning. So for each of those components, during the phone calls, the health educator helped participants to identify goals within those categories, and then specific action plans. How would they move towards those goals between that phone call and the next phone call? These are just some snapshots of a patient booklet we made to go with the patient intervention. You can see Chapter 1, we provide a little bit of background information on arthritis. That's just a snapshot from our weight management section. And then for our physical activity section of the book, we provided general information about physical activity and osteoarthritis, and also included a lot of different examples of appropriate stretching and strengthening exercises for participants. So now let me talk about the provider component of the intervention. The overall goal of that piece was to facilitate use of evidence-based OA therapies. And in a nutshell, what we did was we delivered patient-specific OA treatment recommendations to primary care providers at the point of care. We did that via the electronic medical record, and what we really aimed to do was to have that in front of the provider prior to or right during a non-acute clinic visit. And I'll show you later some data about how successful we were at that. It's a little bit tricky because patients obviously miss visits or reschedule visits, and so sometimes we would put the recommendations in the EMR, patient canceled the visit, rescheduled it for later. So those would still sit there, and they would still be available to the provider that they could view during the visit. Okay, so the recommendations, how do we come up with those? So 2 things fed into what we use as the recommendations to give to providers. First is that they were based on general treatment guidelines for OA that were published at the time of the study start. And then second, we wanted to tailor those a little bit for participants. As you probably know, there's lots of different things that go into OA management. We didn't want to overwhelm providers by giving them just a list of all of those recommendations for each patient. We wanted to pare it down a little bit to any treatments that seem like they may be appropriate. For these treatments that I've listed down here, and I'll go over in a minute, there really aren't specific criteria in the literature or otherwise for when they might be appropriate. For some there are, but for a lot of them it's really just based on clinical judgment. So what we did when we started up the study was work with a number of clinical experts and people who knew the OA guidelines very well, and we developed some algorithms. I'll show you some example of those that would indicate when each specific recommendation went to the provider for a patient. So I'll show you that, but just looking at the list of the recommendations we included, physical therapy, knee braces, referring to weight management, referring to physical activity, For those, you'll see in my data in a little bit, the VA has a specific program called MOVE that is, it includes both weight management and physical activity, joint injections, trying topical NSAIDs or capsaicin, adding a gastroprotective agent or discontinuing an NSAID, so getting at some of the safety issues, trying a new pain medication if the patient didn't feel like the current one was being very effective, and then referrals to orthopedics for discussion of surgery. So that's the potential list. And here are just a couple of examples of the algorithms we use. And I'll just emphasize that this study wasn't really focused on whether the algorithms work so much as whether the idea of providing recommendations was effective. So hopefully our algorithms were based on good clinical judgment, but here's some examples. And these are all published in our methods paper that you can access. You can see all of them. So the first one, just as an example, referring to physical therapy. The criteria we use for that is the patient had to tell us that they would be interested in being referred to PT if their provider recommended. They were not doing strengthening exercises 2 or more times a week. They had to be dissatisfied with some aspect of their function, and they could not have seen a PT for their knee OA or hip OA in the past year. So those are the criteria we use. And I'll just mention, I don't think I did before, that all of the data that fed into these were gathered as part of our baseline assessments for the study. And then you see one more example down there, referring to orthopedics for evaluation for joint plate replacement surgery. They had the radiographic evidence of OA. They had to have tried conservative management, including pain medications, joint injections, and PT. They had to still have pain at a level of 6 or greater. They still had to have functional limitations at 6 or greater. And lastly, they had to say they'd be interested in doing that if appropriate. Okay, so a little bit about our measures and our analyses, and we'll get to some results. The primary outcome was the Western Ontario McMaster University's OA Index, or WOMAC, total score. And then I'll present on just a few of our secondary outcomes today, including the WOMAC pain and function subscales, objective physical function. For that, we use the short performance physical battery. It includes chair stands, an 8-foot walk, and a balance test, body mass index, and then self-reported physical activity. For that, we use the CHAMPS. For all of those outcomes, we use linear mixed models that compared the 2 study groups over time. So this is our consort or flow diagram of participants in the study. I'm not going to go through all of this in detail. It's published if you want to see the details more. But we approached 43 providers, randomized 30 to one of the 2 interventions. And then you can see the remaining flow chart describes enrollment of patients and follow-up of patients. You can see you're randomized 151 and 149, which is obviously off by a couple. It should have been 150 in each. We interestingly had a participant who changed from a usual care provider to an intervention provider after enrollment, so that person was randomized in that group. Lots of interesting things that happen in the context of these kind of effectiveness and pragmatic studies. And then you can see we had good follow-up of participants. 86% and 89% completed the 6-month interim phone calls, and then we were able to catch up with 90% and 92% for 12 months. So a good rate of follow-up. We were pleased with that. So here are our participants. Again, 300 of them. The mean age was about 61. By study design, as I mentioned earlier, about half were white, half non-white, and of the non-whites, the majority were African American, and that's just reflective of the demographic characteristics at the Durham VA. Unlike most osteoarthritis studies, the majority of our participants were male, 91%, and that's, again, characteristics of the VA patient population. About a quarter had some college education. A pretty high percent, 38%, had fair or poor health. The mean BMI was 33.8, so well above, on average, the cutoff for being obese. 93% had knee OA, a little over half had hip, and almost half had both. And then you see the mean duration of arthritis symptoms is around 14 years. So there's obviously some variability in there, but these are largely not patients with new diagnoses of OA. So before I give you the main results, let me tell you a little bit about how things went with delivering the interventions. So for the patient intervention, on average, participants completed 12 out of the possible 18 phone calls. Some of the missed calls are what we called check-in calls. If you remember, early on in the study, we talked to patients twice a month. The second of those calls was a brief check-in call, and those were sometimes missed or skipped if we weren't able to reach people in a reasonable amount of time. So overall, a pretty good completion rate for those. In the provider intervention, we were able to successfully deliver treatment recommendations to the provider for almost all participants. In a few cases, things happened like participants didn't have a study over the 1-year period or other things, but that was rare. And then 68% of the recommendations did get into provider hands within a couple of weeks of a non-acute visit. The reasons that did not occur were, as I mentioned, sometimes people would reschedule visits, and so the recommendations would still be in there, but we delivered them actually ended up being early. And then on some occasions, there were patients who did not have a visit scheduled during the 1-year period. So in those cases, at around 9 months of the intervention, we went ahead and delivered the intervention, knowing that it could happen that somebody scheduled a visit that would occur within their 1-year period. Okay, so let me tell you first about show you some data on referrals. So what I'm showing you here is for the OA intervention group and usual care group separately, how many patients, or the proportion of patients for whom a provider issued a consult or referral for these different types of therapies. So we can look at this pretty easily in the VA medical record and pretty reliably, unlike some other healthcare systems, because it's kind of all internal. If they're going to refer for physical therapy, you'll see that internally within the VA. So we were able to look at those really to get an idea of whether our intervention changed anything at the kind of provider behavior or practice level. And you can see here that there were some changes. So for physical therapy, 12% of OA intervention participants had a referral made during their study visit, compared with 5% for usual care. So not a huge proportion for either, but definitely more for the OA group. For knee braces, 19% got a referral in the OA intervention group compared to 11%. And then the VA's Weight Management and Physical Activity Program, or MOVE, we really saw actually a pretty nice improvement. So 20% of OA intervention participants had a referral for that, compared to only 3% in usual care. Joint injections and orthopedic visits, so those kind of more clinical or medical treatments, we didn't see any really substantial differences. 9% referrals for OA intervention and 11% usual care for injections, and then for orthopedic visits, 5% and 3%. So really it seems like there was some influence on provider practice, but it was more in the kind of behavioral and rehabilitative kind of treatments versus the other specialty treatments. So here are our primary study results. What you're seeing here is in blue, the OA intervention, orange, usual care. 12 months, again, is our primary outcome assessment point. That's when the intervention ended, the patient intervention. And what you're seeing here is an improvement, a statistically significant improvement in the total WOMAC score for the intervention group compared to control. So for WOMAC, lower scores are better, so less pain, less stiffness, and better function. And you can see the interesting pattern that we observe pretty commonly in clinical trials, that there's improvement for everybody kind of in the early phase. But what's important to see is that for the usual care group, that reverts back to about baseline levels at 12 months, while the improvement remained, at least to some extent, for the intervention group. This is showing the pain subscale of the WOMAC. Again, same setup of the figure. So here we saw a little bit of improvement in the intervention group compared to control at 12 months, but it was not statistically significant. However, WOMAC function scale did have a difference between the groups, so more improvement in function remaining at that 12-month time point for the intervention group. So some other outcomes really did not see much change. Slightly better results for the OA intervention. So really they kind of remained stable in objective physical function. Usual care got a little bit worse over time. I suspect that part of what's going on here is that these particular measures may have not been highly sensitive to change in this context. Body mass index, unfortunately, we did not see a difference. So slight decrease in both groups, no difference between the groups. And what I think this may be indicating is that it's just really hard to help people lose weight. And this kind of lighter touch intervention may not be all that's needed for a weight management intervention for people with knee OA. And then looking at self-reported activity with the CHAMS, there was a significant difference here. Right here, what I'm showing you is the number of hours per week of all physical activity. So that includes kind of purposeful exercise as well as other lifestyle kinds of activity of any intensity. And you can see an improvement at 12 months for the intervention group and no change pretty much for the improvement in the intervention group and no change for the usual care group. Similarly, this is showing self-reported activity of moderate or greater intensity. Again, that includes all kinds of activity, but you know, more high-intensity activity. And we do see here an improvement in the intervention group and a slight decrease in the amount of activity in the control group after a year. So what are our main conclusions from this study? Well, we saw improvements in the WOMAC total and function scores, as well as physical activity with a relatively low-cost intervention, and one that was delivered by phone, so one that can really be disseminated pretty widely and could be disseminated centrally. We also saw some increased referral rates for behavioral and rehabilitative treatments. And so another question for follow-up is really what are some strategies for incorporating those kinds of things into the EMR? It's a great opportunity with many more healthcare systems kind of coming into their own EMR and having more capacity to do that, being more familiar with them and being able to incorporate these kinds of things. So I think it's a great question of how might we incorporate what we did here in a more automated fashion, really to prompt providers, when appropriate, to refer to things like physical therapy for knee osteoarthritis. We did see somewhat smaller improvements, I would say, in all outcomes compared to more efficacy studies. So I would classify this study, as I mentioned earlier, as kind of an effectiveness study. It was a little bit of a lighter touch intervention, a very generalizable patient group. I didn't talk a lot about our recruitment, but we didn't rely on self-referral. This was a study population where we reached out to patients, invited them to participate, and I think in those situations we sometimes get kind of more of a range of readiness to change and other kinds of things. So I think our study group is probably pretty representative of what you would see the average patient who just comes to see their primary care provider. So we saw changes, I would say a little bit less of a magnitude than some of the efficacy studies on interventions for physical activity, weight management. Nonetheless, improvement with an intervention that can be practically implemented. So I think there's still some key questions here. One is, how can we maximize the impact of these kinds of practical OA interventions in real-world clinical settings? And then how to foster adherence and maintenance of those improvements. So you probably remember from the graphs I showed, there's more improvement at 6 months. People kind of tailed off a little bit, even in the intervention group, by 12 months. We don't know all of why that is. Sometimes it can just be that lifestyle changes are hard to maintain. We also tailed off our telephone calls from twice monthly to once a month during the last 6 months. And it might have been that us kind of ramping down on those intervention calls was part of that effect of changes kind of tailing off during that second 6 months. So those are kind of open questions, and I think there are some mobile health strategies and other kinds of things that may help us to learn better how to teach patients to maintain those lifestyle behaviors. Okay, and there's acknowledgments of all of the people and organizations who participated, and I think I've left us a few minutes for questions.
Thank you very much, Dr. Allen. That's extremely interesting stuff, and certainly encouraging when we think about, trying to explore ways to get people more moving and to implement some of these kinds of strategies. While people are thinking about their questions, remember you can text them or you can press the raise hand button. I've got one person perhaps raised a hand. Not quite yet. While people are getting their own thoughts together, I did have one question. You kind of led off there at the, finished up with an enticing question about maximizing these interventions and how can we make best use of them. Thinking even more broadly, from our respective experience on the COAMI group and the Osteoarthritis Action Alliance, we're all about trying to implement strategies to improve management and get, physical activity interventions out there. Well, how do you think on a more broad level we can get the word out and get these things implemented in, healthcare systems across the country and for individuals? Are we looking at influencing groups like CMS, insurance, Medicare and Medicaid? Are we looking at professional organizations like the American Medical Association? Who do we tap to get these things broadly implemented?
I think that's a great question. I mean, certainly reimbursement is a big issue. There are big challenges there. I think not only for OA management, other chronic disease management. There's reimbursement now for weight management, for example, but limitations in that only a primary care physician, I believe, can bill for that, and not other kind of support personnel or dietitians. And so I think there's a lot of impact that can be made at the policy level in encouraging reimbursement and documentation, reimbursement for documentation of things like tracking physical function. And there's a lot of things that are challenging with respect to Medicare and Medicaid reimbursement for physical therapy. So I would say, all of those things. I think definitely insurance, Medicare, government has a big role. And then I think on the provider level too, I think there's room to help disseminate guidelines a little bit more. There's work that has been looking at the guidelines recently that a lot of providers, primary care providers in particular, may not be familiar with them. And they're also not easy to, I think, implement. And that's one of the reasons we did this study the way we did, was to give some practical suggestions. Because although, providers might know, yeah, I think physical therapy might be appropriate for an EOA. Well, when do you do it? How often do you do it? Those sorts of questions. I think the guidelines don't provide a lot of practical suggestions for when and how to use them, how to combine them. So I think there's room for reaching out to both providers and then also kind of at the policy level.
Great. Yeah, it is definitely a challenge. We have a couple of questions that have come in by text. The first one is regarding the referrals to other service providers and behavioral interventions. Will you be able to assess how many people were appropriate for these referrals and the proportion of people who actually received these referrals?
We did, yes. So we have those data. I didn't present them today just in the interest of time. But they're in a paper that have submitted, so hopefully they'll be out soon, and I'm glad to provide them if somebody is more interested. So a couple things I will say there. With regard to who was appropriate for them, we can break it down and show how many patients out of those for whom we issued the referral, how many of those were referred versus how many just in general. And I would say there is a more people who had that recommendation were referred than not, and those recommendations were based on our best judgment about who is appropriate for them. The second question, how many patients got them? It's definitely lower than the referrals that I showed you, unfortunately. And so we're actually talking to providers and trying to figure out why that is, and talking to patients. So fewer people, I think it's 12% in the OA intervention, got a referral for PT. Not everybody actually went, and so we're again trying to understand why. I think that part of that is within the VA system. There are limitations on how much PT you can get. Patients unfortunately know there are wait lists, and anybody who's watched the news in the past year knows that there are challenges. It could be also that patients don't want to come back to the Durham VA for their physical therapy. There is a whole boatload of questions out there right now, particularly within the VA system, about why patients may not follow up on referrals that are probably too much to go into here. But again, we're doing this on another healthcare system too at Duke, and so we'll see if we see any differences there in terms of who was referred and how many of those people actually got the services.
And this next question kind of follows on with that. For the patients that were recommended PT or MOVE, did you capture the adherence to these interventions?
So the best we can do with that in terms of adherence is, so we do know who went. Adherence, so far what we've looked at is just whether people had at least one visit for those. So Move also has data on how many people attend certain numbers of visits. So we could look at that. We haven't looked at that yet, but we certainly can, to see once the people who did actually go, how many visits did that attend? That's a great question.
Okay, and so far, one more question by text. Did you have info about how people with just knee or hip OA fared with intervention compared to usual care?
We have not, but we will look at that. That's a great question. Some of the interventions here, like physical therapy, weight management, have a little bit stronger evidence base and effect sizes for knee versus hip. Most people had knee, almost 95%. So I suspect it will be hard for us to look at that in some ways. If I had to guess, I would guess that people with just hip may not have benefited as much, but that's a small percentage of our sample. What will be interesting, I think, for us to look at along those lines is, did people with multiple joint OA do better or worse? Whether that's two knees, a knee and a hip, those kinds of things. I think those are great questions, as well as where at the starting point of symptoms. Do they start off worse? Or disease duration. Do people do better if they get something like this earlier versus later? So those are all questions that we're in the process of exploring, actually.
Great. So at the moment, we don't have any additional questions. We'll give people just another second to think up anything they might want to ask Dr. Allen. And before we wrap up, I'll just take a moment to announce quickly our next webinar coming up on April 15th. Make sure y'all get your taxes done, and then we'll hope to see you for the webinar with Dr. Brian Pietrosimone from the UNC Department of Exercise and Sports Science. I'll be speaking with him for details about his presentation, although I do know his focus is on post-injury joint health. So that will be something to look forward to. As well, don't forget to check in on our events page on our website for all of our upcoming webinars, as well as recordings of past webinars in case you missed one and want to check in. So if there are no more questions, which it looks like there may not be, I would like to just take a moment to thank you again, Dr. Allen. Very interesting presentation and good Q&A. And thanks to all of our listeners for tuning in. And I appreciate your attention today. Thank you very much.